So the first talk is by Dr. Prasanna Venkatesh. He is going to talk on decoding glaucoma module premium edition, shifting from Brooks membrane opening HRW to BMO MRW.
Th Thank you for the opportunity, sir. And next few minutes we'll see on decoding the glaucoma module premium edition, which is upcoming, and it's changing the basics of OCT interpretation, which was traditionally the Brooks membrane opening horizontal rim width, but now the talk is on Brooks membrane opening minimum rim width, how relevant it is in current era. No financial disclosure. And let me start with an animation here. The green line is the internal limiting membrane, and the red line is the Brooks membrane, and the red dot here, as you can see, is the Brooks membrane opening. So once the segmentation of the internal limiting membrane and the Brooks membrane is done, and the red dot, that is the Brooks membrane opening, is marked, now we can see that there is an yellow line which is going through, which is the Brooks membrane opening minimum rim width. That is the smallest distance between the internal limiting membrane and the Brooks membrane opening. So this is what is currently revolutionizing the OCT interpretation. So let us decode it from the point of the spectralis or the glaucoma module premium edition. So what is the true margin of the optic disc? So which is something which is very debatable. So clinically, if you see the inner edge of the sclera, that is the Elsning's ring, was actually defined as a disc margin. I am using this box diagrams on the bottom to convey the concepts better. The sclera, as you can see, was thought to be the true margin. But then in OCT, the termination of the Brooks membrane, which is known as the Brooks membrane opening, is defined as a disc margin. So there comes the confusion. So previously we see the sclera is clinically thought as the real margin, but then the termination of the Brooks membrane is now thought to be the real margin. So definitely both are not the same. As you can see, there is a slight difference between both the anatomical structures. There is two different areas then. One is the clinically assessed area. As you can see that the green dotted lines depicting the sclera. On the right hand side color fundus photograph, the clinically assessed area is taking into account the scleral termination. Then the Brooks membrane, that is the red dotted area, is taking into the account the Brooks membrane opening base disc margin. And then that has a different area. So we'll have to come to some consensus regarding what is the real disc area or the disc margin. Because we have two areas for debate. But then the study by Chowan et al. And others reveal that clinical disc area, you can see it is always larger. That is, the one that sclera shows is always larger than the one that the Brooks membrane opening area shows in normal and in glaucomatous eyes was put to rest. There cannot be two swords in a one sheath, it has to be only one. That is when the study by Chowan et al., as you can see, one of the most popular studies cited by many, gave an end to this discussion that the true boundary of the optic disc margin is the Brooks membrane, because no blood vessels and axons can pass through, putting that debate to rest. So again, coming back to the basics, this is like the Niagara Falls, and I'm just trying to metaphorically correlate with this structure. So the glaucoma module premium edition, what it does is, it selectively segments the Brooks membrane opening. It takes at least 48 Brooks membrane opening. So again, I'm bringing you back to this animation here, where you can see that the internal limiting membrane, the Brooks membrane, the red structure, and the red dot is the Brooks membrane opening. And then it completely gives you 48 sections of Brooks membrane opening. Not only that, it brings into the concept of the minimum rim width. So traditionally what we were doing is, we were just taking the horizontal direction as the horizontal rim width, and we were examining the patient. But this technology has revolution, and it has told that at every 48 segmented sections, it is the minimal distance between the green internal limiting membrane and the red dot, that is the Brooks membrane opening, which should be taken into account. So that is called the Brooks membrane minimum rim width, the smallest distance between those two structures. So every decision goes against something else, isn't it? So when we go to BMO MRW, then we'll have to see why we can't use BMO horizontal rim width. You can see in this figure, the horizontal rim width is different, the minimum rim width is different. So many studies have now come out with this, that the BMO MRW yields a higher diagnostic performance than the Brooks membrane opening horizontal rim width. Even the sensitivity of the Brooks membrane minimum rim width is very consistently high with the retinal nerve fiber layer defect and the HRW. And even this, again, another study done which reveals the same. So also, if you see the visual fields correlations, they were also better with Brooks membrane opening minimum rim width compared to the horizontal rim width. The plots are more concentrated in minimum rim width. The RNFL is also now correlating better with MRW. So again, coming back to the inception of us, every one of us has a different optic disc. That's where we are. So the curse of it is always the size of the optic disc will influence the neuroretinal rim, because every one of us will possess a different optic disc with a different optic size. So imagine a large disc and a small disc having the same neuroretinal rim area. On the left hand side and the right hand side, both the discs seems to be different, but they have the same neuroretinal rim area. A large disc will always have a smaller BMO MRW, whereas a smaller disc will always tend to have a large BMO MRW. But in reality, the neuroretinal rim area is the same. So that kind of an influence will be reduced somewhat when we take the BMO MRW into the equation. So the summary is, when we take BMO MRW characteristics, the BMO is nothing but the disc area. It's another term that OCT is giving into play when we take into OCT. BMO area influences the diagnostic precision of the BMO MRW, but not the RNFL. And if the BMO area increases, the diagnostic precision of BMO MRW decreases. So this is very, very important. What it means is, whenever there is a disc which is bigger, then you go and choose RNFL, because as I showed you in this diagram, this BMO MRW will be smaller. But when you have a disc which is smaller, you can go for BMO MRW, that will be more reliable. So this is a very new terminology that is popping out, and it's a very objective method. It has a lot of additives like GPS system, that is, compared to a traditional OCT, eye movements will be lost, but in this, even when there is an eye movement, it is software picks up. So every time during a progressive examination, same piece of tissue is examined. So that's the beauty about this particular technology. Even with eye movement, even with the head movement or cyclotorsions, the same piece of tissue is again and again examined, and that is what this technology brings into place. So that progressive analysis of glaucoma patient, even when it is very subtle, as you can see in this patient, we can easily settle glaucomatous progression very early. So this concept has been published by myself in the Indian Journal of Ophthalmology in 2021 April issue, as well as a video-based animative guide regarding how BMO MRW is different from BMO HRW is also published last year in IGO videos in the June issue. So please feel free to see those for more information. So I feel glaucoma module premium edition, which is an upcoming terminology, at least in OCT interpretation, is the future glaucoma toolkit and one of the armamentarium of a glaucomatologist. Thank you.
Thank you, Dr. Venkatesh, for a lovely presentation and giving this concept. Any question from this? How much time we have? Just we can take one question. Do you have any question from the audience regarding this? Okay, you said that we can follow it more precisely with this.
Yes, sir.
But then if the variability is the same, because suppose you take whatever we are taking right now, with that also, if we compare it over time,
Yes, sir.
probably the difference will be similar, as you consider this in the beginning to begin with, and then follow it progressively. Have you tried to differentiate between the two or compare?
Sir, personally, that is also possible, sir. With the traditional OCT, which takes the horizontal rim width, that is also a possibility. But what this technology brings into play is the GPS kind of a system, where a small head tilt, or that may even be a game changer, because what it does is, it first marks the macula, sir, center of macula, and then the center of the disc. Then there is a fovea BMO axis. For want of time, I didn't discuss that. So that plotting makes a real lot of difference in mapping the entire sector. But advises, if there is a traditional OCT, then follow up the patient in the same mission. If you are going for this, then follow up the patient in this particular technology.
But this
That
is
also
available
still,
only in spectralis.
this is only, GPS is only
Have
currently.
you seen this minimum rim width progressing in a patient where you have seen progression on perimetry?
Yes, sir, it correlates with the
It
perimetry. Correlates, sir, yes, sir.
Thank you, Prasanna.
No, but one message which I want to give to everyone, that OCT, whenever you are doing, probably he also said that last sentence, it should be always done on the same machine. Because there is no point doing it once in this clinic, second some other clinic, then some third clinic. because then you cannot compare at all. And that is the main function of OCT according to me in relation to glaucoma.
Yes, sir. Ma'am, this is automated,
Automated.
ma'am. Automated, but the segmentation has to be manually corrected. Sometimes,
Yeah.
if the ILM is not segmented properly, yes.
Thank you, Prasanna. So the next speaker is Dr. Jayagopal Agarwal. He's here. Yeah. So his talk is on recent advancement in artificial intelligence application in glaucoma management. So till your presentation is uploaded. So Prasanna's presentations have always had a lot of animations. Actually, your presentations are a lot of teaching tools. So they make you stress on one point, and that point is the take-home message is given. So I think this is a very good presentation, and his work is superb. When it comes to before he started, Nayak sir told 3D में कुछ बोल रहा है. मैंने कहा नहीं sir 3D में नहीं बोल रहा है. But his videos, animations, they really give a take-home message. Thank you, Prasanna. Till Dr. Jayagopal is uploading his presentation on the other podium, we can have Dr. Vinita Gupta.
Yeah.
You have uploaded a presentation. So AV team. You start then.
Thank you. Thank you. Good afternoon. My topic is recent advancement in artificial intelligence in the application of glaucoma management. As you know, the glaucoma is the second leading cause of blindness worldwide. Estimated glaucoma prevalence is 111 million by 2040. In our society, glaucoma is a burden because it is not easily amenable for the diagnosis, mostly asymptomatic, without awareness, and 50 to 90% of glaucoma remains undiagnosed. The current problem is the asymptomatic disease and often diagnosed too late. Our IOP is inadequate to discriminate the normal from the glaucoma. No single most effective screening test. So, what is the solution? We have just been discussing about this overview of the artificial intelligence in the glaucoma. As we are often come across the term that is deep learning algorithm. Here, whatever the data is put inside the input layer, and after the many hidden layers, it analyzes and we give the output. It is very much precise. Now, for example, just this image analysis. Cup and disc is segmented into the 24 cross section to create the CD ratio profile. Shape of the CD ratio profile analyzed with the Origa dataset or the Ramon eye analysis software. This method shows the very high accuracy of the area under the receiving operating curve, that is 99.6 and 91 in the Origa dataset and the Ramon. Ramon is a retinal image dataset for optic nerve evaluation. Now, here we use the OCT in as an artificial intelligence tool in glaucoma. Now, artificial intelligence, when it is introduced in the OCT measurement, it has revolutionized the diagnosis. The artificial intelligence deep learning algorithm using OCT data gives a very good accuracy in detecting the glaucoma and predicting the progression of the disease. Medeiros et al. Used the spectral domain OCT to train the deep learning algorithm to quantify the RNFL thickness and OCT and the optic nerve images. This reduced the discrepancy of the diagnosis due to large and small discs and thereby reducing the variation by the human graded. These gradings are highly reproducible and this takes less time to detect. Another novel method of detecting the glaucoma in the early stage is by the technique called detection of appetizing retinal cell, that is DARC, by SD-OCT when they are highlighted with the fluorescent dye. Similar method of convoluted neural network algorithm predicts the glaucoma progression with accuracy of 97% and sensitivity 85% and specificity is 91.7%. This technique is FDA approved. This is a use of AIOCMTC and with the deep learning system. Here, with this method, we can diagnose the angle closure glaucoma in the early stages. Now come to the tonometry. Here again, it is a old thing, but with a new rule. There is miniaturization of the micro electromechanical system. This is non-invasive diurnal IOP reading. We are example of triggerfish contact lenses. The application of artificial intelligence algorithm to 24 hours IOP profile for the contact lens is to discriminate the chronic open angle glaucoma from healthy eye that gives ARSC 0.6 and clearance is 0.4. Similarly, the IMET intraocular sensor also used to record the 24 hours IOL power, IOL pressure, IOP pressure. Another non-intracameral intervention is episcleral telemetric pressure transduction. Now, another thing with is the automation of IOP estimation by Goldman application tonometer. Automation of estimated by the IOP by analyzing the video recording, we using the slit lamp microscope and Goldman application tonometer. Here, the DL algorithm helps to study the position of the tonometer and the Myers of the recorded videos or estimate the IOP using the Lambert formula. Now, corneal biomechanics using the ocular response analyzer and easily diagnose the open angle glaucoma. Now, there are two types, there's the ocular response analyzers. Now, come to the fundus imaging. When it couples with the data base, it gives a twist. Now, we have many iPad, iPhone based, that is DI system, and Peak Visions, IMAX, Eye Examiner, and the ocular SL phones. Now, come to the perimetry. If it is it takes the help of artificial intelligence. It helps us to interpret the field vision with great accuracy and shorter time with 93% sensitivity and 91% specificity. We have the iPad-based software, that is Melbourne Rapid Field Testing, and Visual Field is easy. And the Review 2 with the glasses of the virtual reality. And we can take the perimetry with this type of glasses. Now, Moorfield motion displacement test is for the glaucoma detection or is a community-based screening. Here we can, it is the community-based screening procedure. It takes the glaucoma detection very easily. Now, contrast sensitivity testing, it is a Smith-Richmond contrast sensitivity test. It also gives the early detection in the chronic open angle glaucoma. Now, electrophysiology is the bone for the glaucoma diagnosis. Here, the N-Goggle technology with EEG correlates steady state of VEP and the pattern reversal is visual stimuli and capture the signal from the 4 OAG and 6 EEG channels. This discriminates the glaucoma eye from the normal eyes. The pattern, these are two pattern electroretinogram. Here I have shown in this picture. Now, come to the community application. Here, first of all, we optic disc-centric fundus photography acquisition through Remedio non-magnetic fundus phone with handheld camera. It is a satellite hospitals, and it is transferred to the main hospitals and for the screening. In the vertical coverage ratio, if it is less than 0.5, it is non-referable. It is more than it is referable. Even the IOP more than 21 millimeter per AG is also referable. Now, at the base hospital, we go for the higher diagnostic tests, and we can get the diagnosis of glaucoma with more precision. Now, Artificial intelligence helps in detecting the glaucoma, but detection of the glaucoma disc from the fundus images, analyzing the RNFL thickness from OCT images, studying the angle structure of ASOCT, studying the visual field images for detection and estimating the progression of the glaucoma, and automated IOP estimation by Goldman application tonometer. There are current limitation also, adversarialization of and black box artificial intelligence, detection of multiple diseases, and need for standard guideline in diagnosis of glaucoma, needs human intervention and need for quality training.
Gopal, can you sum it up,
Now,
please?
now we have many coming diagnostic tools. Now we have got a bright future ahead of us. Thank you.
Thank you, Jayagopal.
So now I invite Dr. Vinita Gupta for neuroprotection in glaucoma, not a mileage.
So if anybody has any questions, please note it down. We'll finish all the presentations first and then take the questions. In case we have time. 1 minute with that. In the meanwhile, Dr. Shweta, please be ready with your presentation.
Good afternoon, everyone. I'll be talking about neuroprotection in glaucoma. We all know that glaucoma is a neurodegenerative disease where there is a characteristically damage to the retinal ganglion cells and their axons. And we have a lot of patients, as glaucoma specialists, we see a lot of patients who have their IOP somewhere in 12, 13, but still they're progressing. So we know that lowering IOP may not be just alone be sufficient. So this is because obviously there are multifactorial factors which are causing this apoptosis and damage to the RGC survival pathways. And they can be in the form of problems in the axonal transport, neurotrophin degenerations, glial activation path getting activated, various pro-inflammatory and oxidative stress which is coming in causing this RGC apoptosis. So the new approach in glaucoma therapy is what is neuroprotection, and neuroprotection is any therapy that prevents, retards or reverses the apoptosis-related neuronal death. And currently available AGMs like Pramodine and some other ROCK inhibitors now do offer neuroprotection, but the next generation therapeutics, there are lots of trials going on, which are animal trials, have already been done, and phase 2, phase 1, phase 3 clinical trials for different types of therapies are going on, which are aiming for RGC survival, RGC protection, rebuilding the neuronal corrections, and latest is what is neuroenhancement. So why is the need there? As I already mentioned, obviously the need is there because IOP learning may not be just sufficient. Despite achieving good IOP control, the patients are progressing. So early neuroprotection may have a role there, obviously in high-risk individuals. And also we are, as glaucoma specialists, we would love to bring back the vision of people who have advanced disease. So obviously the strategies by which this neuroprotection is supposed to work is by pharmacological agents, stem cell therapies, as well as gene therapies. These are the various strategies the way it works. There are various studies which are going on, as I told you, at various clinical trials, various phases are there. And for Pramodine, there is evidence that it works as a neuroprotector, but for the other things, the studies are still in the clinical phase trials of phase 3. For gene therapy is being tried in Leber's hereditary optic neuropathy, and supposedly if this, which is an adenovirus vector associated gene is there, if it works out for that, maybe it can be able to be tried in cases of glaucoma as well. So neuroprotection with topical medications, as I told, we already have enough evidence for Pramodine, where it is said that Pramodine may halt the visual field effects, which may not work with as efficacy in case we are using timolol as the AGM for our patients. And this effect of Pramodine on the neuroprotection is not related to this IOP layering effect, and not related to this ocular perfusion pressure effect as well. So it is a separate effect on its own. For ROCK inhibitors, especially the studies have been there in animal models, rat models, both in vivo and in vitro studies related to the Y27633 ROCK inhibitor. And they have seen that it causes an increased survival as well as a decreased apoptosis of the serum deprived RGC cells. And although these studies have been done in the rat models till now, and also it has been seen that the inhibition of the ROCK pathway by these ROCK inhibitors activates the MAPK downstream signaling pathways that are responsible for, that are used by the ciliary neurotrophic growth factors, which is an important neurotrophin for the glaucoma pathway. So current approaches to neuroprotection, as I said, are strategies. There are 3 ways, there are 3 prongs to it. So one is trying to improve the optic nerve perfusion. Second is trying to rescue the damaged retinal ganglion cells. And third is for trying to regenerate the optic nerve. So the newer agents, some of which are said to improve the optic nerve perfusion, as I said, the ROCK inhibitors are are being supposedly claiming to have some efficacy. In the long run, we still need to see the results with ROCK inhibitors. Which are being, studies have been there which have done topically as well as intravitreal injections are being tried for that. And similarly, we have centrally acting calcium channel inhibitors like nimidopine, which are known to increase ocular blood flow, and as well as flunarizine, which increase the, besides increasing the aqueous outflow, they also inhibit the NMDA activity. And then we have the rescuing strategies by use of neurotrophins. We have various types of neurotrophin factors which are available, which can be applied exogenously, or we can use strategies for causing sustained release of these factors endogenously. So, and they are also being used in other degenerative disorders like Parkinsonism and amyotrophic lateral sclerosis. While strategies which are working, these are by exogenous methods, but for endogenous expression of the injected growth factors, we have use of obviously the growth factor genes, which are being used through vectors. As I said, adenovirus-associated vectors is being used as a vector for infusing these genes for endogenous expression. Then we have transplantation of stem cells or progenitor cells into the retina, which are also being done for various retinal degeneration disorders. And then there is genetic engineering to upregulate the tyrosine kinase receptors. A newer device which is right now being in one of the clinical trials is the Renex, which is a cell-based implant, which is supposed to continuously deliver this ciliary neurotrophic factor into the eye. It is implanted into the pars plana and stays there for life. And it has gone phase 2 trials for RP and macular telangiectasias. And currently, it is also under trial for POAG. Let's see what are the results. We are still awaiting the results for that. And then the last strategy which I told is the optic nerve regeneration, which can be done by blocking the inhibitory signals, by improving the intrinsic growth ability of these cells, and by stem cell transplantations. For optic nerve, for blocking the inhibitory signals, we have the glial tissues. Glial tissue can release inhibitory signals, molecules that signal the RGC to stop growing. So inhibition of these can be done by using NOGO, which is being investigated for certain spinal cord injuries. Let's see if it can be applied to our optic nerve as well. And we have KET3, which is the ROCK inhibitors, which is again, as I told you, is supposed to inhibit the signaling pathways, which can damage these RGCs, exons. And then we have another strategy is by enhancing the intrinsic growth ability of the optic nerve, where this is a gene therapy-based approach to target the transcription factors. And this is again mainly being targeted for the ciliary neurotrophic growth factor and also other growth factors. And then finally is the stem cell transplantation for the optic nerve regeneration, where but the challenge with this therapy is that obviously we will have to transform these injected cells which we have grown into the RGC phenotypes. Whether we are able to achieve that, we are still under experimentation right now. We have so many experimental studies. We have had so many animal models, rat models, where these studies have been done and where they have been successful to some extent, but we have not been able to translate quite a lot of these studies into human clinical use. This is because we need to use so many pathways simultaneously. There may be problem with the drug delivery systems, as I told you. There may be, we need lots of vectors for that. How much reproducibility will we get when we are translating into human eyes? And obviously we know the human eye may not be behaving exactly the same as the rat models. And since we know this disease glaucoma is a long disease with a long follow-up, with a slow progression. And finally, the issues of obviously the money. The funding is always an issue everywhere. I'll just finish my talk in the end by talking about this neuroenhancement. Neuroenhancement is basically seeking to rescue the cells which are not totally dead, but they are dysfunctional. So it is targeting therapeutic window between the dysfunction and the cell death. So this is a very, very promising tool. And it is said maybe citicoline, certain neurotrophins may be acting, as well as separate electrical stimulation may act at this level, for which it is important to recognize the apoptosis retinal cells by
Dr.
using
Vinita,
this dark,
can you please sum up?
This last slide. By using this dark new technology which is there, which is a non-invasive technology where annexin 5 is bound to a phosphodiesterine, which is utilized as a probe after labeling it with fluorescein, and then an argon laser is used to excite this fluoroprobe, and a confocal scanning laser ophthalmoscope is used to detect these marked fluoroprobes. And by this, we will be able to identify the cells which are about to die. They are not actually become dead, but they are in the stage of apoptosis, and probably we can target these cells as therapies. So to conclude, obviously IOP layering still remains the first neuroprotectant, but there is enough motivation to translate all these animal studies into human studies, and neuroenhancing will, with neurotrophins, holds promise. Thank you.
Thank you, Vinita. So Dr. Shweta, all yours. I request all the speakers to please stick to the time. There's a timer which is running in front.
So a very good evening to all, and especially to our esteemed chairperson, Dr. Nayak sir, and all the chairs. And at the outset, I would like to thank AIOS for giving me this opportunity. So let's understand that why this holistic approach of glaucoma patient is important, and what does that mean? That means that you don't have to treat the number, you don't have to treat the pressure alone. You have to treat the patient. That's how the holistic approach comes from. So let's get started talking about this particular case where a 50-year-old female presented to us in 2016, and she was diagnosed and worked up as a DIS suspect, and right eye was having only inferior slope. Though everything else was within normal limit, and she was advised for a review to the clinic after 3 months. But due to her non-compliant nature, she presented to us maybe 15, 16 months later, that was December 2017, with the chief complaints of occasional heaviness. And by this time, the patient was on irregular use of AGM, which were prescribed elsewhere. On examination, we could see that there was a notch in the right eye, which was a slope initially. So what we did is that we started the patient on, restarted on the beta blocker, and along with the lubricating eye drop. And the patient was asked to review back again in the clinic. But again, this time, the patient came to us 8 months after the second presentation, and with a chief complaint of redness and sometimes on and off pain in the eye. Sometimes, majority of the time, it used to be like red eye, silent red eye. Now the patient had stopped the AGM on her own, and on slit-limb examination, there was a diffuse conjunctival congestion with the rest of the anterior segment within normal limits. That means there was no AC activity working in the eye at that particular moment. Pressures were 18 in both the eyes, and the patient was treated for conjunctivitis along with topical antibiotics and lubricatings and the restartment of AGMs once again. This is the pattern of the IOP trend, which trend over a period of 1 month, say from 4th September to 27th September, where we can see that the IOP were raising, coming down on their own. That was an erroneous change in the IOP pattern, along with the redness of the eye, going down, redness, then coming up. There were no, in the meanwhile, we got the patient investigated. There was no evidence of sclerouveitis, along with no further involvement of posterior segment as well. The patient was put on oral Vicilone, despite the fact the pressures were again going up and coming down. And we had to keep on adding the AGF. So these were the investigative reports for the patient. So this was the time for us to replay the sequence that happened on 11th/9, that is 11th September. That was after 2 or 3 visits in September month. So the thought-provoking points in our patient was that the recurrent attack of diffuse conjunctival congestion with no other signs of inflammation, that was alarming to us, and the fluctuating IOPs. And the significant negative signs which the patient was having was that there was no evidence of proptosis or any kind of inflammation anywhere else in the eye. So we went back and we took a detailed history further back, and where she gave the history of episodes of fever with no diurnal variation. UTI treatment, she said that she had taken that irregular. On seeing the urine reports, hematuria was there noted for 10 days, and urine routine showed protein and RBC positive. On taking further history that the patient was not having any dyspnea, cough, or hemoptysis, immunologist opinion was sought. She was further detailedly investigated, to which she came out to be ANCA positive, with a urine routine protein having the RBCs. Renal biopsy was done, and a diagnosis of granulomatosis with polyangiitis, crescentic glomerulonephritis was made. And as we all know, that's a life-threatening, deadly condition. So the patient was with the help of the physician and the immunologist, was put under the treatment for rituximab cycles, along with the omnacotil, that's oral steroids. And to our uttermost satisfaction and happiness, the BVAS score, they improved from 15 to 0. This is again the pattern after 1 month of treatment with rituximab. As we can see that the pressure had started coming back on its own, despite the fact that the patient was still on oral steroids as a maintenance therapy. And the IOP was also coming down, the eye was becoming quiet, and gradually, to our uttermost satisfaction, we could withdraw the AGMs one by one. And at the last follow-up visit, the patient was only on a single AGM, that's beta blocker, along with a well-controlled IOP, that's 14 millimeters in both the eyes. The diagnosis was reached with the help of this particular criteria, which is used for the diagnosis of GPA. And the learning milestone here was that the holistic approach to achieve the aim of saving the patient's life and preventing the blindness. Just a few words about this particular condition. Sometimes this is the first ocular manifestation is the involvement when it comes to treating a case of a vaginous granulomatosis, and most commonly orbital involvement is there, or sometimes it could be the chronic conjunctival inflammation. So in our case, it was a redness of the eye which raised the alarm with the erroneous raising of the IOPs. So again, I would conclude my presentation with the learning milestone that recurrent red eye and IOP spikes, perseverant systemic history taking with comprehensive management really helped us a lot to save the patient's life and bringing back controlling the vision loss for her. Thank you very much.
Thank you, Shweta, for finishing before time. And we'll take the questions at the end if time permits. So now I invite our scientific committee member, Dr. Jatinder Singh Balla, to talk on recent advances in medical management of glaucoma.
Thank you for the opportunity. The topic I am going to cover is the recent advances in pharmacotherapy for glaucoma management. We all know glaucoma is a chronic progressive optic neuropathy and its leading cause of irreversible blindness, and the single most important modifiable risk factor is the control of intraocular pressure. Glaucoma is a growing concern, and 80 million people affected by 2020, and this figure is going to increase to 112 million, that is increase of about 32 million by 2040. But unfortunate part is that in India, 12 million people are affected, 1.2 million people are blind from the disease, and more than 90% of these cases remain undiagnosed. But we have come a long way as far as pharmacotherapy of the glaucoma is concerned. About 1876, we had a drug like pilocarpine. 100 years later, we had beta blockers in 1978. Then we had in 1987 alpha agonists like brimonidine. Then carbonic anhydrase inhibitors. 1996, we have prostaglandin analogs. 2017 saw the advent of Rho kinase inhibitors. So where is the need for newer drugs when we have so many drugs in our armamentarium? We want drugs with improve the health-related quality of life, which offer neuroprotection. Patients have known allergy or side effects to the existing drugs. We want drugs with longer half-life, more potent, lesser side effects, and there is also need for preservative-free drugs that are economical. So there is advent of these kind of drugs like latanoprostin bunod 0.024% and ROCK inhibitors with prostaglandins, and all of these drugs are still not available in our country. So what is new in the medical management? There is drug like latrancolin B, which causes mean reduction of intraocular pressure of 32% to 34%. Drugs like nitrogen monoxide donors like latanoprostin bunod. Why they are effective is because these nitrogen oxide synthetase, they relaxes the trabecular meshwork cells and inner wall of the Schlemm's canal, besides increasing the uveoscleral outflow and also increasing the ocular blood flow. And what is the efficacy? They cause more reduction in intraocular pressure compared to the prostaglandins like latanoprost. And there are studies like Lunar and Apollo which have demonstrated that latanoprostin OD dosage was non-inferior to timolol, and another study, Voyager, has concluded that latanoprostin bunod 0.024% had better IOP reduction than latanoprost. So that is, it shows more efficacy than prostaglandin analogs. Coming to the PGA analogs, we all know that the first prostaglandin that was approved by FDA was latanoprost, next was bimatoprost, and then in 2014 we had tefluprost. We all are aware that there are 9 types of receptors that have been identified for prostaglandins in the human body, and these are PGFP and PGE receptors. These are 2 main types of receptors present in the human eyes, and they are mainly located on the Schlemm's canal and trabecular meshwork. But there are exciting future developments in PG analogs, and these are that the only drugs approved right now are for PGF2 receptors, and current research strategies are focused on targeting PGE2 and PGI2 receptors. Like latanoprostin bunod is a PGF2 analog, sulprostone and butaprost are PGE2 and PGE2 agonist, and iloprost is PGI2 analog. Then we have sustained release implants like bimatoprost sustained release implant, which delivers drugs over 4 to 6 months. There is travoprost intracameral implant, which again is efficacious over the period of 4 to 6 months, achieving IOP reduction of 30%. BKC-free drugs are again the need of the hour because over 70% of existing multi-drug formulations contain benzalkonium chloride and they promote inflammatory markers. So they cause delayed hypersensitivity and allergic reactions, and 40% of glaucoma cases are also associated with ocular surface disease, and hence BKC-free products are now considered as preferred choice. These are some of the BKC-induced allergic reactions. So there are technologies like self-dispersion nanotechnology, where the drug is surrounded by oil and non-ionic stabilizers. Then this was talked to by Dr. Vinita Gupta and Dr. Shweta also, that there is now technology in the horizon where there is real possibility of detection of apoptoizing retinal ganglion cell, and ANX776 has been is a marker with which we can detect these apoptoizing retinal ganglion cell. And imagine when you are able to detect this apoptoizing retinal ganglion cell, there is another drug which has been tried in transgenic mouse line, that is apoptosis inhibitor. Diagnose apoptizing ganglion cell and give apoptosis inhibitor so that the glaucoma, even at pre-perimetric stage, is really taken care of. Gene therapy has also been talked about. Trabecular meshwork is a favorite tissue for gene transfer. LAC-Z reporter gene, caveolin 1, caveolin 2, angiopoietin-like 7 are some of the genes which are being now talked about as far as the gene therapy for glaucoma is concerned. But the current IOP, if we talk about IOP lowering medication, they currently have drawbacks. That is, none of them are acting against the real mechanism, pathophysiology, that is increased outflow resistance. Then beta blockers and alpha agonists do not act during nocturnal period, and many patients are unable to tolerate these drugs because of the side effects. So need of the hour is agents with a novel mechanism of action which are effective during both diurnal and nocturnal periods, and which also support retinal functions and which have minimal side effects. So that saw the advent of drugs, newer class of the drugs like Rho kinase inhibitors. And Rho kinase inhibitors, how do they act? They act at subcellular level. I'll just explain this slide. You will find that at the margin of the trabecular meshwork cell, you have actin-myosin complexes. And these myosin-violet complexes, when they get aggregated, they cause rounding of the tip of the trabecular meshwork cell. And so what happens is, at subclinical, subcellular level, the outflow resistance, that is the pore size in the trabecular meshwork, increases and the outflow resistance decreases. So the ROCK pathway mechanism is just taken care of. So I'll just conclude that the ripasudil and netasudil are some of these drugs which are the cannabinoids, melatonin, connective tissue growth factors. All of these have been talked about. Neurotrophic factors in neuroprotection. So the future looks exciting. Although the currently lowering of IOP remains the only treatment strategies, but the sustained drug delivery system and personalized medicine, which really take into account your genetic makeup and then targets with the gene therapy, is maybe the newer future. And newer medications may be able to extend the duration of medically controlled glaucoma. Preservative-free drugs may help in preserving ocular surface, and alternative methods of delivery for glaucoma medications may be a key factor in improving outcomes with currently available medication. Thank you.
Thank you, Dr. Valla. I invite Dr. Arup Chakravarti, Editor Proceedings, for presenting his talk on exfoliation syndrome and glaucoma.
Good evening, friends. What we refer to as exfoliation syndrome or exfoliation glaucoma was first described way back in 1917 by Lindbergh. Since then, the disease has manifested in its various manifestations, and we have got to understand the condition more. And today, this syndrome may be defined as an age-related generalized disorder of the extracellular matrix, characterized by the production and progressive accumulation of a fibrillar extracellular material in tissues throughout the anterior segment and also in connective tissue portions of various visceral organs, and is the most common identified cause of open-angle glaucoma worldwide. So as I just mentioned, it involves the eye in a very diffuse manner, including the anterior segment as well as the extrabulbar tissue, as well as have involvement in systemic locations, particularly the visceral organs. We are concerned about ophthalmic manifestations, mainly in glaucoma. But at the same time, you must remember that patients with exfoliation syndrome play an important role in the management of cataract because of certain pathology that is associated with this disorder. These patients have poor mydriasis, an extended blood-aqueous barrier breakdown, endothelial decompensation, retinal venous occlusions, usually associated with homocystinuria. And whenever I get a patient with exfoliation syndrome or exfoliation glaucoma, I make it a point to have the patient referred to the internist so that a proper cardiovascular and cerebrovascular workup is done. As regards etiology, about 40% of the patients with exfoliation syndrome will develop glaucoma eventually. And coming from the other perspective, about 20% to 25% of patients with open angle glaucoma worldwide will have exfoliation syndrome. The study done in Shankar Netralaya showed that urban population had a lower prevalence than the rural population in terms of developing, showing exfoliation syndrome. And ocular hypertension increased the risk of these patients developing, going into the glaucoma stage. As regards the mechanism, open angle mechanism is more important. There is the final common pathway is increased outflow resistance in the trabecular meshwork because of the cellular dysfunction at the trabecular cell level, trabecular meshwork blockage by the exogenous or endogenous exfoliation material, blockage by the iris pigment, and increased aqueous protein concentration. Angle closure mechanism is less common, and it is usually associated with progressive zonular weakness, increasing lens thickness, increasing adhesiveness of the iris to the lens anterocapsule of the lens, so on and so forth. Relative anterior microphthalmos is also quite commonly seen in these patients. Now, as regards the course of glaucoma, as I just mentioned, that exfoliative material is a risk factor for glaucoma, and EMDT showed that ocular hypertension patients with exfoliation syndrome is two times more likely to go on to develop glaucoma than patients without exfoliation syndrome. This kind of glaucoma has a very highly progressive nature. They present at a higher IOP. The diurnal IOP variation is much more. So if you see this particular curve, the upper curve is the patients with exfoliation glaucoma, and it has a very rapid and very steep curve, very rapid progression. So probability of developing glaucomatous optic neuropathy is higher in eyes with exfoliation glaucoma than other forms of glaucoma, same eye levels. The glaucomatous neuroretinal dim damage tends to be more diffuse with exfoliation glaucoma as opposed to the sectorial preference in primary open-angle glaucoma. Differential diagnosis in a true capsular delamination, primary amyloidosis, pigment dispersion. As regards treatment, all medical, lasers, and surgical treatment have been found to be useful to treat different stages of the condition. Many of these patients, treatment should be begun early, but many of these patients eventually go on to surgical therapy requirement. Now, I would start off the patient with a bimatoprost. There are studies showing that it is better than many other prostaglandin analogs. I would have a lower target IOP and ask them to come back for a more frequent follow-up situation. And if I have to step up therapy, then I would use a combination of prostaglandin analog and timolol in these patients. The SLT is effective in both exfoliation glaucoma as well as primary open-angle glaucoma, and in a more or less similar manner. And SLT and ALT both have more or less similar role to play in exfoliation glaucoma. In patients with occludable angles, if patient has cataract, of course, patient goes for cataract extraction. Otherwise, EAC-PI definitely helps. And these are the surgical options. I have experience in doing trabeculectomy for these patients. The surgical technique is basically routine. Mitomycin C is used routinely for all these patients. And postoperatively, these patients are put on topical steroids for a longer period of time. Many of these patients have combined them with cataract surgery, and that's a different thing altogether. This is a study which was published last year, which compared the various surgical management strategies in patients with exfoliative glaucoma. And it concluded that there are several trials, but there is insufficient evidence to determine whether any particular surgical or laser technique is superior to another. So in conclusion, exfoliation syndrome is seen about 3% to 6% of the population. Urban population had lower prevalence. It is seen overall 40% of patients with exfoliation syndrome will go on to develop glaucoma. An estimated 20% to 25% of the patients with open-angle glaucoma worldwide have exfoliation syndrome. Once glaucoma is present, it is much more aggressive, generally with poorer prognosis. and patients will require multiple medications, and frequently this is escalated to surgical management. At present, we don't have sufficient evidence to determine whether any particular surgical or laser technique is superior to another. And proper patient counseling as regards the various systemic issues and surgical outcomes is very, very important. Thank you very much for your attention.
Thank you, Dr. Arup, for finishing before time. So we have 4 minutes left. I'll just put up one question to the panelists so that we can have at least one question on each topic. So the question to Dr. Rahul Deshpande. Dr. Rahul, do you have any experience at your center with AI, which Dr. Jay Gopal talked about?
With what?
With artificial intelligence in glaucoma or retina? I mean, do you have any experience? Your
No.
center is holding anything?
No, no. Right now we are not using it.
So AI is a new thing which is going on. Dr. Moria also has worked on that, and we have Remedio who is working on AI and has come up with AI in retina and glaucoma. But still, it's an evolving tool and promising tool also. We need to have more experience in that. Coming to the neuroprotection and medical management newer approach, Dr. Vinita and Dr. Balla, I just wanted to ask anybody in the panel if they can reply. Are you all using any of these neuroprotective agents like dorzolamide, ROCK inhibitors, or brimonidine solely as a neuroprotective agent? Anybody?
Hello. Yeah, just we have started using brimonidine. We were using, but now we are starting the ROCK inhibitors. But
No, my question is, these three molecules have a role in neuroprotection. There are varying studies which reports that they have a role in neuroprotection. But are we, any one of us are using solely this molecule for the purpose of only neuroprotection?
First of all, let us ask the speakers itself.
Not yet.
Do you use these medicines considering the mind that, okay, we are giving it as a neuroprotection? Or just because these are all theories which have been going on for a very long time?
Madam, please.
Pamidine has been used just like in cases, mild cases of glaucoma, I would not prefer to use Pamidine, maybe I would prefer to use Pamidine. In my cases, I would.
No, that is your preference, but then there is no solid basis for this because but Loge's study is something which is not meant for this, number one. Number two, before that, when brimonidine was launched, that time when the company was so clever, they used to talk about the experiment, the crushed injury. And after that, but then there was no, and then after that, they used to talk about this drug. So it means it's not that directly telling that this is neuroprotection, but indirectly so that you correlate that, okay, now because this is talked after this, immediately after that, so this drug has neuroprotection. It's not, because I don't think, and this neuroprotection, in 1998, there was a conference in that Weinrub, I specifically asked, do you foresee, because he was talking about neuroprotection, foresee in near future, or when do you see that neuroprotection will be available for clinical practice? He said, maximum 10 years. Now 25 years have gone, nothing has come.
So the reason to ask this question was for the there are a lot of PGs also around. So we should not give a wrong message that for neuroprotection, you can start one of these three molecules so that for future your nerve is regenerated or kept generated all the time. So this was one thing which I wanted to highlight. Dr. Ruma, you have anything to say?
So we're using brimonidine, but we're not using it.
Audience, can I please have a silence with the session still going on? Audience, can we please lower the voice? Yeah. Yeah, Dr. Ruma, we couldn't hear you.
We are not using any of the drugs for neuroprotection.
Okay.
I think Dr. Shweta also highlighted very important point that it is just not that we are treating glaucoma and it needs a holistic approach. Many times the patients, they keep on progressing and sometimes there is a reduced diastolic perfusion pressure or there is other vascular disorders which are leading to progression of glaucoma or maybe there is some Valsalva maneuver which are they regularly doing. So it is a holistic approach. We should actually intervene and go and talk about history more, that why it is progressing. So I think that was a very important topic she also highlighted.
Just last one comment for the talk of, Dr. Arup. Exfoliation syndrome in glaucoma. One take-home message is they are fast progressors, they need aggressive management, they need frequent follow-ups, short follow-ups. So this is the take-home message which I wanted to give for that talk. And with this, we come to the conclusion of this session. We have 5 minutes, so I request all the speakers and the panel chairpersons to come for a group photograph.